Nephrotic syndrome is characterized by massive proteinuria 1 gram per meter square per 24 hour, hypoalbuminemia, less than 25 gram per liter, generalized edema and hyperlipidemia greater than 200 milligram per deciliter. The management of nephrotic syndrome. Clinical features, clinical manifestations, then physical examination and investigation. Clinical features is common in between is common in between 2 to 8 years. They are present for the first time and may have the history of previous attacks of facial puffiness, massive periorbital swelling, generalized edema, scanty micturition, color of urine is usually normal. Most important clinical features: generalized edema and scanty micturition. Generalized edema and scanty micturition. Other features are facial puffiness, massive periorbital swelling, and color of urine is usually normal. Associated features of complications: cough and respiratory distress, pneumonia, pleural effusion, Hughes ascites. Associated features of complications. Associated features: cough and respiratory distress, abdominal pain, redness and tenderness of the skin, fever and dysuria, diarrhea, then neurodeficit like hemiplegia, Cough and respiratory distress indicates pneumonia, pleural effusion, and Hughes ascites. Abdominal pain indicates gut ischemia, peritonitis, inflammation of the peritoneum, and renal vein thrombosis Skin pain, redness and tenderness of skin indicates cellulitis. Fever and dysuria indicates UTI, urinary tract infection. Diarrhea, impaired absorption of food due to gut edema, neurodeficit like hemiplegia. Diarrhea, impaired absorption of food due to gut edema, neurodeficit like hemiplegia, stroke from thromboembolism. Physical examination. Signs secondary due to hypoalbuminemia, signs related to diminished circulatory volume, and signs related to complications. Signs of steroid toxicity related to hypoalbuminemia. Swelling of the eyelids, extending to the chin and neck. Swelling of the eyelids, extending to the chin and neck, double chin. Hughes ascites with or without parietal edema. Parietal edema. Edema of the scrotum. edema of the scrotum and penis with cracks and fissuring of skin and exudation. Edema of the scrotum with penis, edema of the dependent parts of the body like ankles and clinical evidence of pleural effusion. Clinical evidence of pleural effusion and increased respiratory rate. Edema of the scalp. Edema of the scalp. Signs related to diminished circulatory volume. Signs related to diminished circulatory volume. Diminished circulatory volume. Pulse weak, low volume. Pulse, body extremities may be cold. BP usually low. Capillary refill time prolonged. Pulse, then temperature, BP, capillary refilling time. Pulse, low volume, body extremities temperature low, cold, body temperature extremities cold, BP usually low, and capillary refilling time usually prolonged. Signs related to complications. Peritonitis, inflammation of the peritoneum, shiny abdominal wall, rigidity, tenderness and absent bowel sound. Shiny abdominal wall, rigidity, tenderness and absent bowel sound. Renal vein thrombosis. Renal vein thrombosis. Palpable kidney with hematuria. Palpable kidney with hematuria. Then stroke. Signs of steroid toxicity. Cushingoid faces, buffalo hump, abdominal stria, hirsutism, hypertension and cataract. Muscular weakness. Investigation shows urine RME, for diagnosis. Number 1 for diagnosis. Number 3 for screen infection. Number 4 to assess renal status. Number 5 to find out etiology. Number 6 to understand renal histology. Urine RME, albuminuria, granular and hyaline cast. Pus cell if associated with UTI, RBC and WBC, RBC cast. Diagnosis 24-hour urinary total protein. 24-hour urinary total protein greater than 1 milligram per meter square per day. Spot urine protein. Is to creatinine ratio greater than 2. Serum albumin less than 25 milligram per liter. Serum cholesterol greater than 220 milligram per dl. This is confirmatory. How? অ্যালবুমিন থাকা লাগবে 25 নিচে। আর হলো তোমার প্রোটিন ইউরিয়া 1 মিলিগ্রাম পার কেজি পার মিটার স্কোয়ার পার ডে। 1 মিলিগ্রাম পার মিটার স্কোয়ার পার ডে, সরি গ্রাম। প্রোটিন হলো গ্রামে, অ্যালবুমিন গ্রামে, আর কোলেস্টেরলটা হচ্ছে মিলিগ্রাম। হ্যাঁ, স্পট ইউরিন প্রোটিন টু ক্রিয়েটিনিন রেশিও 2 এর উপরে থাকতে হবে। টু স্ক্রিন ইনফেকশন, ইউরিন আরএমই অ্যান্ড কালচার অ্যান্ড সেন্সিটিভিটি, ইউরিন আরএমই অ্যান্ড কালচার অ্যান্ড সেন্সিটিভিটি, সিবিসি, পিবিএফ, ESR, CBC, PBF and ESR, blood for culture and sensitivity, blood for culture and sensitivity. Then X-ray, chest, then X-ray, chest. To assess renal status, blood urea, nitrogen and creatinine. Then serum electrolyte, ultrasonogram of chest and abdomen, to find out the etiology, blood for HBs antigen and anti-hepatitis C virus. Then blood C3, C4, then ANA, NT-DS, DNA. To understand renal histology, we do renal biopsy. The treatment of nephrotic syndrome, specific treatment and supportive treatment. Treatment of nephrotic syndrome, specific treatment and supportive treatment. Specific treatment, হ্যাঁ। আবার আসছে ফার্স্ট ইনিশিয়াল অ্যাটাকে কি ট্রিটমেন্ট দিবা, এটা শুধু দুইবারই 12, 11, 14 দুইটাতে ইনিশিয়াল অ্যাটাকে কি দিবা। স্পেসিফিক ট্রিটমেন্ট প্রেডনিসোলন। ফার্স্ট অর ইনিশিয়াল অ্যাটাক, single oral daily morning dose of first or initial attack, single oral daily morning dose of 60 milligram per meter square per day, or 2 milligram per kg per day for 4 to 6 weeks, followed by 40 milligram per meter square per day, followed by 40 milligram per meter square per day, followed by 40 milligram per meter square per day, or 1.5 milligram per kg per day, one alternative day for another 8 weeks, to 5 months, relapse attack, initial attack, then relapse attack. Urine protein creatinine ratio, urine protein creatinine ratio greater than 2 and 3 plus protein on deep stick testing for consecutive 3 days in patients who were on remission previously. Single oral morning daily dose 60 milligram per meter square per day until patient has achieved remission for 3 consecutive days, and switch to alternative day therapy varies depending on the frequency of relapse over a period of 12 months. Observation or their inability to remain in remission following discontinuation of prednisolone. Supportive treatment: diet, fluid, management of edema, then infection, thromboembolism and immunization. Diet: normal family diet adequate with protein urea. Normal family diet adequate with protein. Salt restriction is not necessary, as no added salt diet is okay. Patient can take rice, vegetables, meat, fish, egg without yolk, dal, milk, sugar, etc. Fluid: liberal fluid intake in mild edema, and severe edema restricted to 400 milli per meter square plus output of previous day. Management of edema: in mild edema, avoid diuretics. In mild edema, severe symptomatic edema, hospitalize the patient. Restrict sodium and fluid. Oral furosemide and oral spironolactone. Oral furosemide plus oral spironolactone. Infection, antibiotics, thromboembolism, low molecular weight heparin and warfarin. Finally, immunization. Nephrotic syndrome. The nephrotic syndrome is characterized by massive proteinuria, 1 gram per meter square per 24 hour, hypoalbuminemia less than 25 gram per deciliter, generalized edema and hyperlipidemia, greater than 200 milligram per dl. Management of nephrotic syndrome. Clinical manifestation common in between 2 to 8 years. They may present for the first time or may have history of previous attack of facial puffiness, massive periorbital swelling, generalized edema and scanty micturition. Facial puffiness, massive periorbital swelling, generalized edema and scanty micturition. Generalized edema and scanty micturition is more important. Color of urine is usually normal. Associated features of complications: cough and respiratory distress indicates pneumonia, pleural effusion and huge ascites. Abdominal pain indicates gut ischemia, peritonitis, renal vein thrombosis. Pain, redness and tenderness of skin, cellulitis. Fever and dysuria, UTI. Diarrhea, impaired absorption of food due to gut edema. Due to gut edema. Neurodeficit like hemiplegia, stroke from thromboembolism. Stroke from thromboembolism. Physical examination, signs secondary due to hypoalbuminemia. Signs secondary due to hypoalbuminemia. Swelling of the eyelids. Swelling of the eyelids extending to the chin and neck. Double chin. Huge ascites with or without parietal edema. Edema of the scrotum and penis with cracks and fissuring of skin and exudation. Edema of the dependent parts of the body like ankles and back. Clinical evidence of pleural effusion. Clinical evidence of pleural effusion and increased respiratory rate. The edema of the scalp. Edema of the scalp. Signs related to diminished circulatory volume. Diminished circulatory volume. Pulse weak, low volume. Blood extremities may be cold. BP, blood pressure usually low. Capillary refill time usually prolonged. Signs related to complications. Peritonitis, shiny abdominal wall, rigidity, tenderness, and absent bowel sound. Renal vein thrombosis, palpable kidney with hematuria. Palpable kidney with hematuria, then stroke. Signs of steroid toxicity, cushingoid faces, buffalo hump, abdominal stria, hirsutism, hypertension, cataract, and muscle weakness. Investigations, urine RME shows albuminemia, granular and hyaline cast, pus cell if associated with urinary tract infection, RBC and RBC cast. For diagnosis, 24-hour total protein 1 gram per greater than 1 gram per meter square per day. Spot urine protein creatinine ratio greater than 2 and serum albumin less than 25 milligram per dl. Serum albumin 25 gram per dl and serum cholesterol 250 milligram per dl. To screen infection, urine RME, culture and sensitivity, CBC, PVF and ESR, blood for culture and sensitivity, X-ray, chest. To assess urine status, blood urea, creatinine, serum electrolyte, ultrasonogram of chest and abdomen. To find out the etiology, blood for HBs antigen and anti-hepatitis C virus, blood for C3 and C4, ANA, anti-DS, DNA. To understand renal histology, renal biopsy. Treatment of nephrotic syndrome, counsel the patients about the nature of disease and prognosis. Specific treatment, prednisolone. Specific nephrotic syndrome, specific treatment of nephrotic syndrome is prednisolone. First attack or initial attack, single oral daily morning dose 60 milligram per milligram per meter square per day or 2 milligram per kg per day for 4 to 6 weeks, followed by 40 milligram per meter square per day or 1.5 milligram per kg per day for another 8 weeks to 5 months. Then relapse attack, urine protein creatinine ratio greater than 2 and 3 or greater than 3 plus protein on dipstick testing for consecutive 3 days in patients who were on remission previously. Single oral daily morning dose 60 milligram per meter square per day until patient has achieved remission for 3 consecutive days and switch to alternative day therapy varies depending on the frequency of relapse over a period of 12 months. 12-month observation or their inability to remain in remission following discontinuation of prednisolone. Supportive treatment. Supportive treatment consists of diet, normal family diet, adequate with protein, salt restriction is not necessary, no added salt diet is okay. Patient can take rice, vegetables, meat, fish, egg without yolk, dal, milk, sugar, etc. Fluid. Liberal fluid intake in mild edema. Several edema restricted to 400 milli per meter square. Plus output of previous day. Management of edema. Mild edema. Avoid diuretics in mild edema. Severe hypotonic edema. Severe symptomatic edema. Hospitalize the patient. Avoid sodium and fluid. Oral furosemide, oral spironolactone. Infections, antibiotics, and thromboembolism, low molecular weight heparin, warfarin, and finally immunization.